Hi, Dr. Ashley.
Okay, excellent. Hi, Gabby. Hi, how are you?
Hi, I'm good. How are you?
Okay, good. Yeah, good, excellent. So, okay,
Well, hi,
so
everyone.
before,
Thanks so much for jumping on. The topic for the live this evening is ultrasounds in IVF. So before I ask Dr. Asti some questions, Asti, could you please give us a brief introduction on the topic?
okay, so today we'll be discussing ultrasound scans. So I will give very overall overview first, and during question and answer, we can describe different types of ultrasound scans we do during IVF treatment. So generally, ultrasound is, of course, is one of the main tools we use in IVF. So there are different types of ultrasound scans. So you can the ultrasound scans have a different terminologies in terms of when you request scans. You can have a simple gynecological ultrasound scan, you can have a fertility ultrasound scan, then you can have a deep pelvic ultrasound scanning, then you can have IVF monitoring ultrasound scanning during fresh IVF cycle. Then you can have ultrasound scan as a part of ovulation induction, frozen embryo transfer, IUI cycles. So there are different types of scans you can have in IVF. So we will be describing each and every ultrasound scan during today's live stream, and you can so that you can understand what's the difference between scans. Because when you do certain type of ultrasound scan, you can pick up some pathologies. Then patients can get surprised. Say, look, I had this ultrasound scan. Nobody said that I had this condition, because that was a different type of ultrasound scan. Yes, it is ultrasound of the pelvis and ovaries, but different level of scanning or different type of ultrasound scan. That's why certain pathologies may not be detected in certain scans, but later on we can detect during IVF cycle or during deep pelvic ultrasound scanning.
Great, thank you. Could you please explain what is a baseline fertility ultrasound?
Starting IVF treatment or before you see fertility specialist, your GP requests baseline fertility ultrasound scan. So depending on where you will have a scan and the level of expertise or specialization, so you may just end up having simple gynecological ultrasound scan, which says ovaries look normal, uterus looks normal, we can't see any pathology. So that's a very basic gynecological ultrasound. It's not fertility ultrasound. Fertility ultrasound should have a very specific type of systematic investigation. So in fertility ultrasound scan, generally we want to find out if there is any pathology. First, we want to find out if there is any pathology which can cause infertility first, any pathology which can cause problem with the creation of eggs and embryos, and any pathology which can affect your implantation in IVF, and also is there any pathology which can impact your pregnancy negatively. So that's much more systematic scan than gynecological scan. In gynecological pelvic ultrasound scan, essentially sonographer wants to find out if there is any cause of gynecological problems like heavy menstrual period, painful period, or any sign of endometriosis, ovarian cyst. That's a very basic scan. So in fertility scanning, in baseline fertility scanning, we have a minimum requirement. So minimum requirements are to diagnose any ovarian pathology like ovarian cyst or like chocolate cyst or dermoid cyst. So, and also we want to find out your antral follicle count. Any ultrasound scan which doesn't tell us antral follicle count is not fertility scan. That's just gynecological scan. So antral follicle count means the sonographer should measure all the follicles on your ovaries and count how many follicles you have less than 10 millimeters. That's antral follicle count. This is very critical information for fertility specialists because antral follicle count tells us about your egg reserve. It's same as AMH. So AFC, which is antral follicle count, has a very similar power in terms of uh, diagnosing your ovarian reserve as AMH. So that's why if I see ultrasound scan which doesn't tell me antral follicle count, that's not fertility scan, that's just gynecological scan. So yes, an antral follicle count is measured and counted by measuring each and every single follicle on your ovaries on the right and left, and adding a right and left antral follicle count together, which tells us your egg reserve. So, and also basic fertility scan should exclude hydrosalpinx. Why? Because hydrosalpinx may not be that significant in gynecology, but it's very significant in fertility investigation or treatment. Because if you have hydrosalpinx, that can reduce the chance of implantation. That we need to treat that hydrosalpinx before doing embryo transfer. So then also fertility ultrasounds can give us a very good information about the uterus, uterine size, uterine texture, like whether it's homogeneous or heterogeneous uterus, which can actually tell us whether you may have adenomyosis or not. And also it should tell us whether there's any abnormality in the uterus, like Mullerian abnormalities like arcuate uterus, bicornuate uterus, or septate uterus. And also it should tell us about endometrium. Is there any polyp inside the endometrium? And also endometrial thickness according to your menstrual cycle. Let us say if you're doing scan in the mid-cycle, your endometrial thickness should be more than 7 millimeters. And also should tell us whether there's any fluid inside the endometrium. So these are the minimum requirements for baseline ultrasound scan. On the basis of that, then we can try and understand what could be the cause of infertility and make a planning for fertility treatment, including for IVF treatment.
Thank you, Dr. Asti. Speaking of ultrasounds in an IVF treatment, what is involved in an IVF monitoring ultrasound?
So IVF monitoring ultrasound scan, so we do two types of monitoring ultrasound scan in IVF, which is for fresh cycle when you're doing ovarian stimulation, and second is for frozen embryo transfer cycle. The purpose of these monitoring scans are different. In fresh IVF cycle, when you have a menstrual period and start ovarian stimulation with the FSH hormones, so in IVF ultrasound scan or IVF monitoring overall, we need to ensure a couple of things. One, we need to know how your ovary is responding to stimulation. Second, we need to make sure that you haven't ovulated by the time you reach the egg collection. So for that, ultrasound scan generally can be started from day 7, day 8. So, and on ultrasound scan, very systematically, sonographer measures each and every follicle on the ovary. So mainly we are here interested on ovaries. Yes, at the same time we scan the uterus, but mainly here we're interested in ovaries. We count each and every single follicle on the ovaries and the size of those follicles. That tells us how your ovary is responding to stimulation. Any follicle which measures less than 1 centimeter is called antral follicle. This follicle is there, but it's not been activated. It's not going into the growth phase of your follicle development. So any follicle bigger than 10 centimeters, 10 millimeters, 1 centimeter, is already activated. That's growing follicle, which is potentially can become mature and can give you egg. So we need to count how many follicles, all follicles, small and big, antral follicles and growing follicles. All follicle sizes should be measured and then we plot on the chart. So on the right and left ovary. So that helps us to understand how many follicles got activated after stimulation hormones, FSH hormones. And then we need to decide whether these follicles are big enough for triggering or not. And also we need to decide whether we should increase the dose of FSH if the follicle is not getting activated, or reduce the dose of FSH, or stop the FSH altogether before we trigger. So that's very, very critical for us to know exact size of follicles and how many follicles are growing and how many follicles are antral follicles which are not growing on both right and left. That's a follicle, it's called folliculogram scan, which means we are scanning to check follicle sizes and number of follicles. And at the same time, the sonographer during IVF monitoring, fresh IVF cycles, they check the uterine again size, the uterine contour, because if some pathology was there which wasn't detected in initial fertility baseline scan, we want to pick up. So let us say adenomyosis, for example, it may get undiagnosed during initial ultrasound scan, during monitoring, we screen for adenomyosis. We check if there are any signs of adenomyosis, like Venetian blind sign and shadowing, subendometrial buds, or myometrial cysts. If we pick up, then usually the fertility specialist gets notified, then so that we can make a very individualized plan. So also, if there's any uterine fibroids, that those fibroids get assessed, and endometrial polyps, if there is endometrial polyp, that gets assessed. And most importantly, especially if you're planning to do fresh embryo transfer, we want to check the endometrium. Endometrium, you check by checking endometrial thickness and the character of endometrium. For example, to rule out Asherman syndrome, we need to check if there's any adhesions inside the endometrium or echogenic lines or any fluid inside the endometrium. So especially in patients doing fresh transfer, we need to make sure the endometrium is optimal. And the endometrium, generally, we want to be more than 7 millimeters without any fluid, without any interrupted lines, so that we can do a fresh embryo transfer. So, so yes, ovaries get assessed for follicle sizes and numbers. Uterus get assessed to exclude any adenomyosis or uterine fibroids. Endometrium gets assessed to exclude endometrial polyps and endometrial pathologies or any sign of Asherman syndrome, and also we assess endometrial thickness in fresh IVF cycle when we are doing ovarian stimulation. In frozen embryo transfer cycle, we want to, if we are doing natural cycle, stimulated, natural, modified natural, or letrozole natural, or just simple natural cycle, we want to make sure that there is a follicle growing and the ovulation is happening. So, and we use a hormonal test to make sure that this synchronous follicle growth is happening and ovulation is going to happen. And also we check endometrium again. So uterine uterus, like muscle, like to rule out adenomyosis and fibroids, and endometrium as well. So monitoring scans are not as thorough as other scans like the deep pelvic ultrasound scanning or baseline fertility scanning, but again, each scan we take it as opportunity to screen for any pathologies which might not have been detected in previous ultrasound scans.
Thank you so much for that detailed explanation. Could you please explain what a deep pelvic ultrasound scan is?
Yes, so deep pelvic scanning is the most comprehensive ultrasound scanning, which is indicated in patients when we suspect there is a deep infiltrating endometriosis or adenomyosis or any uterine pathologies like fibroids or endometrial polyps, which needs more thorough examination. So the difference in deep pelvic scanning, first, it's done by expert sonographers. Usually they are gynecologists or very experienced sonographers with training and specialization for endometriosis ultrasound scan and adenomyosis ultrasound scan. First, this is first requirement. Second is usually these scans are done in specialized tertiary level imaging centers. So you may have a simple radiology centers, so where the scans or gynecological or baseline ultrasound scan for fertility can be done by the radiologist. They're not quite specialized in one area. They can do generalist ultrasound scanning, but deep pelvic scanning is done in tertiary level scan sonographers or gynecologists with expertise in diagnosing of deep pelvic ultrasounds, deep pelvic endometriosis and adenomyosis and other uterine pathologies or gynecological pathologies. So also usually they use, generally they use much more powerful machines, and they do 3D scanning as well. So that's very, very comprehensive, thorough ultrasound scanning. This is one requirement. And also deep pelvic ultrasound scanning uses criteria called MUSA criteria for assessment of uterus. For assessment of ovaries, they do thorough scanning, antral follicle count is included. If there's any uterine ovarian pathology, that's scanned. And let us say you have ovarian cyst, then that's they describe the nature of the cyst. Is it looking like hemorrhagic cyst, endometriotic cyst, or dermoid cyst, or is it looking more, sinister cyst, which is very, very rare in women undergoing fertility treatment, but it may happen. So they give a very good description of your ovaries, and also you have a very detailed description of uterine anatomy as a part of MUSA criteria, which we can discuss later. So, and here the purpose is to rule out adenomyosis, which is not easy diagnosis to make, especially if it's very early adenomyosis, deep deep endometriosis, and any ovarian pathology. So, and the simple scanning, simple gynecological scanning or fertility scanning, you may not be able to diagnose deep infiltrating endometriosis, but in deep pelvic scanning, it can be diagnosed. There are certain features, like, for example, if you have a pelvic adhesions because of endometriosis, if you have endometriotic nodules infiltrating to the bowel or bladder or uterus, in deep pelvic scanning, you can detect, and it's not as sensitive diagnostic as laparoscopy, but the level before the doing laparoscopy, you can do deep pelvic scanning to rule out deep infiltrating endometriosis.
Thank you, Dr. Asti. We do have a comment from a follower. Right, Colette asked, is this typically included in pre-IVF assessments, that being a deep pelvic ultrasound scan?
Very good question. Generally, no. So because so essentially the deep pelvic scanning is we request deep pelvic scanning in patients who have a repeated implantation failure, who had a 2 or 3 failed embryo transfers, or when we suspect deep infiltrating endometriosis, like stage 3, stage 4 endometriosis, and if we suspect adenomyosis. Because this is a very thorough scan in certain, depending on which country you live in, and level of insurance cover, this type of scans can be quite expensive. So it's generally not indicated to offer to all patients or request all patients to go through the scanning, because a lot of patients actually they do not need this level of ultrasound scan, and they don't have a pathologies like we mentioned earlier, and they get pregnant easily after 1 or 2 embryo transfers. But in patients with repeated implantation failure, adenomyosis, endometriosis, or any other uterine pathologies we want to have a very thorough examination for, we request the pelvic ultrasound scanning.
Thanks so much, Dr. Asti. Earlier in your explanation of a deep pelvic ultrasound scan, you touched on MUSA criteria. Could you please talk to that in a little bit more detail?
Yes. So, so to diagnose a uterine pathology, we need a very systematic assessment, because 3 different people, if scan the uterus, they can describe 3 different ways. So simple in gynecological ultrasound scan, they can just simply give you uterine measurements and say the uterus looks normal, and normal measurement. That's one way of describing the uterus. Another person, this is like very basic primary level scanning. So secondary level of scanning is you can get for the same patient, you can get a description of uterus saying the exact size of the uterus and a little bit of more description of uterus. So uterus's size is this, and it looks like there is some small uterine fibroid, and some very basic description of uterus. So then for same uterus, if that patient has got adenomyosis, for example, you may have a very thorough description of uterus. So in order to minimize minimize missing certain pathologies, and now we have got criteria called MUSA criteria. So in the MUSA criteria, you need to describe uterus very systematically so that we do not miss any pathologies which may cause problem for our fertility patients. The MUSA criteria are used for gynecological conditions as well, for uterine fibroids, adenomyosis, but for fertility patients, especially when we want to rule out adenomyosis and any other uterine pathology, we want sonographers to use the MUSA criteria. It would be ideal if all sonographers used MUSA criteria, But certainly sonographers who's doing deep pelvic ultrasound scan, we request them to use, but they use anyway because they are just minimum standard. So they're so good that they use MUSA as a minimum standard, and they go above and beyond the MUSA criteria. On MUSA criteria, we want sonographers scan systematically and report systematically. So from the surface of the uterus, first the sonographer should report the surface of the uterus, say uterine surface or contour from outside is normal, smooth. It's not attached to bowel. Let us say they can use a different techniques like sliding technique on TV scanning to make sure that nothing is attached to the uterus, like bowel is not attached to the uterus, bladder is not attached to the uterus. Uterine surface is smooth and free. If you have a lot of adhesions on the uterine surface, that indicates there is a severe endometriosis going on. It's attached to the front or side or behind the uterus because of endometriosis or pelvic infection, PID, or you may have a hydrosalpinx, which may causing a lot of adhesions. So they describe uterine surface. A second, they describe overall structure of the uterus. So the size of the uterus is very important. For example, in adenomyosis, enlargement of the uterus may be only sign of adenomyosis. Because of inflammation of adenomyosis, uterus can get swollen, can become bigger. So generally, we want uterus to be less than 100 cc's. If you have a bigger uterus without all the explanation, without having any fibroid, for example, that indicates this uterus is swollen, very likely due to inflammation. And usually the main cause of inflammation is adenomyosis or endometriosis. So size of the uterus is very important for us to know, and the structure of the uterus, like shape of the uterus. So shape means that whether this patient has got any Mullerian abnormality, like bicornuate uterus, arcuate uterus, septate uterus type, or uterine diaphos having two uteri. So, and that MUSA criteria, the description should be uterine contour is normal, and the size is this, let us say 80 cc's, and uterine shape is normal. There isn't any abnormality in terms of structure. Then systematically they need to describe the muscle layer of the uterus. That's the middle thickest layer of the uterus. So if there's any lesion in the muscle layer like uterine fibroids, they need to describe. So how many uterine fibroids are there, and the exact size of the fibroid and the location of the fibroid. And there is a FIGO criteria for reporting. So where the fibroid is sitting, is it subserous or in the middle of the uterus, intramural, or in the mitral, like submucosal? So they have to describe exact size and location of the fibroid. And also they need to tell whether this uterine muscle layer is a smooth, we call homogeneous, which should be normally homogeneous, or heterogeneous, or which means it's not very smooth. That generally indicates if either there is a lesion, which is usually fibroid, or adenomyosis. So uterine, if muscle is not very smooth, that means there's some pathology there, usually inflammation, which is adenomyosis or fibroid. So also then they need to describe if muscle layer of the uterus has got features of adenomyosis. So adenomyosis is by definition of the growth of the endometrial lining into the muscle layer. So endometrium, which is the lining of the uterus, should not grow into the wall of the uterus. So if it does grow into the wall, then it causes certain signs on ultrasound scan. So endometrial lining looks very bright on ultrasound scan. So we call echogenic. So muscle layer looks more darker. So if endometrial lining ends up in the wall, you see this bright spots in the wall of the uterus, which should not be there. So we call echogenic, hyperechogenic islands. So that's a sign of adenomyosis, which means adenomyosis endometrium is growing into the wall. So, or you can have a cystic spaces in the wall, inside the uterine, inside the muscle layer. So that's another sign of adenomyosis, which means when you have a menstrual period, when you bleed outside, you're bleeding in the wall of the uterus, and that blood is getting stuck, and then you can see as a fluid collection in the wall. Any place, anywhere if you see the fluid collection, we call it cyst. So if you have a lot of cystic spaces, that means yes, there is adenomyosis growing in the wall, which we don't want, of course, in IVF. So, and also when you have a description of the muscle layer, the sonographer should tell if there's asymmetrical thickening of the wall. So front wall of the uterus and back wall of the uterus should have a same measurement. If one wall or even side walls should have a similar measurement. If you have a thickening of front wall or back wall, one of the lateral walls, side walls of the uterus, that indicates very likely there is endometriosis growing, adenomyosis, which is type of endometriosis growing in that part of the uterus. Why it's thick? Why it's asymmetrical? Because inflammation causes swelling of that local part of the uterus, and then you have a asymmetrical thickening of one side of the wall. So that's a sign of adenomyosis. Okay, so far we described surface of the uterus, we described overall structure of the uterus. Now we described the muscle layer of the uterus. Next layer is called junctional zone. So junctional zone is a zone between endometrium, which is inner layer of the uterus, and the muscle layer of the uterus. So that's very, very critical for us to know what junctional zone looks like. Why? Because this is a place where implantation happens. So implantation happens in endometrial plate, and all these blood vessels, all these lymphatic vessels, which is responsible for immune system, all of them located in junctional zone. So this junctional zone is a transition zone between lining, which is endometrium, and the muscle layer. So if you have adenomyosis, usually you have a problem in that junctional zone. So we want, in MUSE criteria, sonographers to describe this junctional zone in very detail. So normally junctional zone should be very thin. Generally it should be less than 11 millimeters. And also it should be very smooth, very regular, without any like white lines. White line means endometrial lining is going into the junctional zone. So we call regular, smooth junctional zone. So if junctional zone becomes bigger, thickened, which means inflammation happening. Wherever you have inflammation, you have a collection of fluid, and that causes thickening, enlargement of that area. So, and also when you have an irregular junctional zone, interrupted junctional zone, that means there's an adenomyosis. So what happens is in adenomyosis, so endometrial lining has got two layers. Inside line, it's got two layers. It's implantation bed. So one layer is called basal layer. That's stem cell layer. It stays there. So you have a basal endometrial plate. It doesn't go away. So then you have a functional layer, which is every month, because of estrogen, it grows, because of progesterone, and then it gets detached. So then you see it as menstrual period. The menstrual blood is actually this functional zone of functional layer of endometrium. So in adenomyosis, you have a breach in the endometrial plate, in the basal plate, and endometrium starts growing into the wall. So essentially, like let's say uterus is like a room, you have got plaster board, which is endometrial plate, then you have a breach in that plaster board. Every time you bleed, you start bleeding inside the wall, inside the brick layer of the uterus. And that layer gets sealed off every month, and you start bleeding. Then you have a stem cell of endometrial basal endometrium. It starts getting seeded, and every time you have a period, you start bleeding in the wall. So you have a crack on the surface of the uterus. When you do scan, you can see those cracks. We call subendometrial lines, which means you can actually see the cracks on a scan, white lines breaching into the wall of the muscle. And we also call it subendometrial buds, which means you have got breach, then you have got pooling of this stem cell endometrium and growing like a bud, budding into the wall of the uterus. Then also in MUSEC criteria, the sonographer should report if there is interrupted subendometrial plate, which means you have got irregular interruptions, like defects. Like let us say the plaster board is gone, now you have got defect. So you can actually see through that defect. So you have a white line of endometrium coming, then there's nothing. Then this edge is not meeting, then you have got defect, which is just muscle layers exposed. That's what adenomyosis can cause, breach an endometrial plate. So endometrial plate where your embryo should implant. Just imagine embryo is trying to implant, you have got big defect. So that's what, if that is the case, the scan should report to us. That's why scan is very critically important tool in IVF. Scan should report as a MUSE criteria. So junctional zone can easily get reported as a normal, which is a regular, smooth, not swollen, without any defects, or it can be reported as a with defects, subendometrial buds, subendometrial lines, irregular, interrupted. So interrupted junctional zone means yes, you have got adenomyosis. So this is a description of junctional zone on MUSE criteria. The next level, now we described surface of the uterus, we described muscle of the uterus, structure of the uterus, we described muscle of the uterus, we described junctional zone of the uterus. They go from outside to inside of the uterus. Now the last layer they need to describe in MUSE description is endometrium, which is endometrial lining where the implantation happens. This is a bed for embryo. So in endometrial description is inside uterus. They need to describe first endometrial thickness. That's very critical to know, depending on the time of your menstrual cycle. If in the middle of your cycle, after day 8, day 9, day 10, your endometrium should measure more than 7 millimeters. If it's thin, so it may mean that you may have a scar tissue or Asherman syndrome, adhesions inside the uterus. So that needs to be described. And also they need to describe whether there's any pathology going into the endometrium, like endometrial polyps. That's the commonest pathology of endometrium, and or submucosal fibroids, which is fibroid going into the uterine cavity. They need to describe that. In measurement and harmony of those they can see. And also, when the description happens of endometrium, they need to describe if there is any fluid in endometrium. Yes, initially in menstrual period, if you had a scan while you are having period or just after menstrual period, you may see some leftover fluid. But after day 7, day 8, you should not see any fluid inside the uterus. So if there is a fluid, it indicates either the drainage of the uterine cavity is abnormal. Let us say, for example, if you had the stenotic cervix, for example, if fluid is getting collected, not draining out, or there is a overproduction of fluid inside the uterus. Endometrium always replenishes with the fluid, the surface, and should get absorbed quickly enough so that you should not see the fluid. But in two conditions, you may have three conditions, you may have this overproduction of fluid. First is adenomyosis. This inflammation fluid may, like uterine wall muscle becomes like sponge. Then after menstrual period, it keeps discharging fluid into the cavity. It can get collected. That fluid is inflammatory fluid. It's harmful to the embryo. Second condition is hydrosalpinx. From fallopian tubes, the fluid gets collected, fluid can get flushed back into the wall, uterine cavity. That's toxic fluid. And also in isthmusal, when you have a cesarean section, if some fluid is left, and that fluid can get collected and then can get flushed back into the cavity, and that's also toxic fluid. Or if you have a stenosis of the uterus or Asherman syndrome, for example, you may have a scar tissue where drainage is impacted and the fluid can get collected after the period, and that fluid is also toxic to the embryo. So the description of endometrium should include description of the actual endometrial thickness. Then they should write today, day 15, for example, of menstrual cycle, endometrium measures, let us say 8 millimeters. Second, it should describe whether there's any pathology like endometrial polyp, fibroid, and whether there's any fluid inside the endometrium, and whether any scar tissue, like if you have a scar tissue, if you have very good sonographer, they can see scar tissue, which is Asherman syndrome. So like lines crossing endometrial lining. So, and also they need to describe inside the uterus, like shape of the uterus. Let us say, for example, if you have uterine septum, they should describe there's a septum, which is a uterine abnormality going into the uterine cavity from the fundus ceiling of the uterus. So they need to describe that in detail, and after that they need to describe whole pelvis. So first you describe surface of the uterus, then you describe muscle of the uterus, then you describe junctional zone of the uterus, then you describe endometrium of the uterus, then overall pelvis, like if you have hydrosalpinx, uterine adhesions, any like endometriosis surrounding uterus, and MUSA criteria that needs to be described. So we wish as fertility specialists, every time you have a scan, your scan is reported on MUSA criteria, which doesn't happen often because it takes a long time. It's a very thorough scanning. So, but in patients where we suspect uterine pathology, we normally request the sonographers to do deep pelvic scanning, or even if they can't do deep pelvic scanning, or do the scanning using MUSA criteria for diagnosis and reporting of uterine pathology.
Thank you so much, Dr. Rasi. That was really insightful and a very detailed explanation of MUSA criteria. My final question for this live, could you please explain what is hycosi?
Yes, so hycosi generally we do before IVF to, especially if patients planning ovulation induction or IUI, to ensure that the fallopian tube is open. So, and in IVF setting, which is our live stream is dedicated on IVF only, in IVF setting we request hycosi in 2 occasions. First occasion is to check if there is Asherman syndrome. So when we suspect Asherman syndrome, which is an intrauterine adhesions, usually happens after DNC, after miscarriages, after retained placenta, when it wasn't diagnosed early enough, then you have a scar tissue formation inside the uterus. So we request either, first we request like deep pelvic scanning, to find out more about this pathology and possible other pathologies of the uterus. And second, we can request hycosi to be sure about the diagnosis, or hysteroscopy, which is a gold standard for that, which means directly visualizing inside the uterus. And if you see Asherman syndrome or scar tissue inside the uterus, you can open up and remove the scar tissue. The advantage of hycosi before doing hysteroscopy, first is you don't need anesthetic, it's less invasive, and it's less costly than hysteroscopy. If you're not quite sure whether there is a Asherman syndrome or not, we normally request hycosi first. If diagnosed, then hysteroscopy. If we know certainly there is a Asherman syndrome according to history, and according to science we are seeing on ultrasound scan, we can directly send patients to hysteroscopy. In hycosi, you do deep like in internal transvaginal ultrasound scan, but you inject fluid, either contrast fluid or normal saline, into the uterine cavity while you are scanning. What happens is when you inject the fluid, cavity gets expanded and you can see through the cavity easily. Wherever there is a fluid, that fluid gives us a window to see the structures. So when you put the catheter and put the fluid in, you can see the cavity. If you have, let us say, Asherman syndrome, for example, you can see the dividing bands of the scar tissue in the contrast of the fluid. So you can see that and you can clearly diagnose. So this is one reason for requesting hycosi. Another reason for requesting hycosi is diagnosing uterine abnormality. Like if you're not quite sure whether there is a septum or not, sometimes arcuate uterus without septum can look like septate uterus. In arcuate uterus, you don't need any treatment. In septate uterus in IVF, you want to remove the septum before doing embryo transfer. If you're not quite sure, then if you do hycosi can clearly show up whether there's a septum or just the shape of the uterus is bicornuate or arcuate. So these are two main reasons why we request hycosi in IVF setting.
Thank you so much, Dr. Asti. This live was very detailed and comprehensive. So thank you so much for sharing your expertise in this area. And thanks those for joining and for your questions. So tomorrow's live, we will discuss Asherman syndrome, which Dr. Asti did briefly touch on earlier. So we will talk to that in more detail tomorrow. So thanks so much, everyone. Thanks, Dr. Asti.
Thanks, Gabby, for organizing it. Thanks, everyone, for joining the live stream. Have a wonderful evening.
Thank you.
Thank you.
Bye.
Thank you.